Hi guys, it's Met by Health Hush. In today's video, we'll be discussing about rheumatoid arthritis. Rheumatoid arthritis. Rheumatoid arthritis, in my previous video, the introduction to arthritis, I mentioned that it's a type of inflammatory arthritis. Inflammatory arthritis means that there is an inflammation to the synovial layer of the joint capsule. So if we see rheumatoid arthritis, it's a slowly progressive symmetrical peripheral polyarthritis, which means that this disease is gradually progressing, and when they have lesions, when their joints are being affected, it's symmetrically affected, and also polyarthritis means multiple joints are being affected. So in this picture, we can see that the joints are usually affected symmetrically, which means that the both sides are being equally affected, and it may initially begin in couple of joints only, and then most frequently the attacks are very common in the wrists, hands, the elbows, shoulders, knees, and ankles. So rheumatoid arthritis is an inflammatory arthritis. Inflammatory arthritis means that these patients are having joint pain and stiffness in the early morning. So, patients with rheumatoid arthritis, they have persistent joint pain and stiffness. And if you see the premature mortality rate, in these patients, the premature mortality rate is high. It's mainly due to increase in vascular events like coronary artery diseases and stroke. And this disease is very common in people with age between 30 to 50 years. If we see the etiological factors, before menopause, females are more prone to be affected than males, and after menopause, females and males are equally affected. And rheumatoid arthritis is also known to have a genetic factor as well, which is HLA-DR4 gene is the one that causes rheumatoid arthritis. If you see this diagram, in this diagram you can see the normal side of a joint and then the affected side of the joint. So, in the normal side of the joint, we can recall the anatomy. We have the joint capsule, which is made up of two layers, the fibrous layer and then the synovial layer. Then we have in between the joint cavity, which is filled with synovial fluid, and then we have the articular cartilages. And this side is the affected joint with rheumatoid arthritis. Let's look into the pathogenesis. Since this is an inflammatory arthritis, which means that there is an inflammation in the synovial layer of the joint capsule, we can see that the synovium becomes thick and muscle bulk-like appearance. So in this picture, we can see that the synovial layer is more thick and it looks like muscle bulk when compared with the normal side of the synovium. And in the synovial fluid in the joint cavity, we can see that there is presence of polymorphonuclear leukocytes, predominantly lymphocytes. So this is the pathogenesis of rheumatoid arthritis. And also in rheumatoid arthritis, we need to keep in mind that there are two main serological markers. So first one is rheumatoid factor. So if you see rheumatoid factor, it is an autoantibody of IgM, IgA, or IgG, which is acting on the Fc portion of IgG. So in this immune complex, the antigen part is the Fc portion of IgG and the antibody is the IgM. So it's an autoantibody, antibody acting against an antibody. So the autoantibody of IgM, for example, is acting on the Fc portion of IgG, forming an immune complex. So once the immune complexes are being formed, it activates the complement and also stimulate inflammation in the synovium, causing chronic synovitis. So if you see this rheumatoid factor, mostly when we do test, we check autoantibodies of IgM against Fc portion of IgG. So this IgM rheumatoid factor could be positive or negative. It being positive does not confirm the diagnosis, as well as it being negative does not exclude the diagnosis. Presence of rheumatoid factor IgM means that the synovitis is more active and the joint is damaged more, and there is a greater disability of the joint. And it being negative does not exclude the diagnosis of rheumatoid arthritis. It means that it is a seronegative rheumatoid arthritis, which means that these patients suffer from rheumatoid arthritis, but they do not have the serological markers. And also there is another serological marker which is more specific than IgM rheumatoid factor. This anti-CCP means anti-cyclic citrullinated peptide antibody. Presence of this antibody is more specific to diagnose rheumatoid arthritis than presence of rheumatoid factor. Now let's see some clinic of rheumatoid arthritis. So as I said, these patients suffer from persistent joint pain and stiffness. So they have pain and stiffness mainly of small joints. If you see the hands, metacarpal phalangeal joints, proximal interphalangeal joints are more commonly affected than the distal interphalangeal joints. It's very rare. And if you see the feet, metatarsal phalangeal joints are more affected. And there are some joints other than the joints that are present in hands and feet. Temporomandibular joint as well as the atlantoaxial joint, which is present in the cervical spine, and sternoclavicular joint is also affected by rheumatoid arthritis. But these joints are being affected very rarely, or we could say it's not rarely but less common. So if you see that cervical spine and sternoclavicular joints are more likely to be affected than the temporomandibular joint. And also there are some specific features we can find in hands of these patients with rheumatoid arthritis. The first feature is ulnar drift. So in this patient we can see ulnar drift. We can see that the fingers are being deviated towards the ulnar side of the hand in both hands. And then our next feature is palmar subluxation of metacarpal phalangeal joints. So in this X-ray we can see that there is a subluxation of metacarpal phalangeal joint. Subluxation means that the joints are not in place and it is only being in touch with each other partially. It's not at the right place. And also there are two main specific signs as well, which is boutonniere finger and swan neck sign. Boutonniere means there is a fixed flexion and swan neck means there is a fixed hyperextension of the proximal interphalangeal joint. So in this picture we can see boutonniere deformity and swan neck deformity. Boutonniere deformity, as I said, it's a fixed flexion. So in this patient we can see the proximal interphalangeal joint with a fixed flexion, and in the swan neck deformity, as I said, it is hyperextension of the proximal interphalangeal joint. So you can see that there is a hyperextension. And as I said, the distal interphalangeal joints are being affected very rarely in case of rheumatoid arthritis. And in cervical spine, we can see atlantoaxial subluxation. Now let's try to diagnose rheumatoid arthritis. In this picture, we can see the classification criteria to diagnose rheumatoid arthritis. In classification criteria, we need to speak about the joint involvement, which joints are being tender and swollen, and as well as the serological markers, whether there is an acute phase reactant, and the duration of symptoms in these patients. So if you see the joint involvement, if it is just one large joint is affected, then the score is 0. And then if 2 to 10 large joints are affected, we give him 1 point. And if 1 to 3 small joints are affected with or without large joints, we give 2. And if 4 to 10 small joints are affected with large or without large joints being affected, 3 points. And if more than 10 joints are being affected with at least one small joint being affected, we give 5 points. And then we have to see the serological markers. So if the rheumatoid factor and ACPA means anti-citrullinated protein antibody, which is also same like anti-CCP. Anti-CCP means anti-cyclic citrullinated peptide antibody. So if these both serological markers are negative, it's 0 points, and if they are low positive, 2 points, high positive, 3 points. And then we go to acute phase reactants. CRP and ESR usually in patients with rheumatoid arthritis is elevated. So if it is elevated, you get 1 point. If it is normal, 0 points. And we need to see the duration of the symptoms. If the duration of the symptoms is more than or equal to 6 weeks, we also give 1 point. So altogether, we need to calculate how much score this patient gets, and if it is more than or equal to 6 to 10, then you definitely have rheumatoid arthritis. Now let's see what other tests that we will do in rheumatoid arthritis. We will check the full blood count. The patient can also have anemia. And we have to see the serological markers, anti-CCP, rheumatoid factors, and antinuclear antibodies. And in X-rays, we can find subluxation of joints. And if we do aspiration of the joint fluid, which is the synovial fluid, we can find polymorphonuclear leukocytes, predominantly with lymphocytes. And how do we manage rheumatoid arthritis? We give for pain NSAIDs, and NSAIDs will give some side effects for these patients, so we also give them COX-2 selective inhibitors. And to treat these patients, we give DMARDs, methotrexate, sulfasalazine, hydrochloroquine, and leflunomide. And also we can treat them with new biologics, for example, like etanercept, infliximab, adalimumab, anakinra, and rituximab. So this is a brief discussion about rheumatoid arthritis. See you guys in my next video.